Hello and welcome to the guideline session on preoperative investigation from the Indian Society of Anesthesiologists. I am Dr. Umesh and I feel really privileged and honored to present these guidelines. I would like to thank the office bearers of ISA Bellary branch for giving me this wonderful opportunity to present the guidelines. Well, formulating these ISA guidelines was actually the brainchild of Dr. Balabhaskar S. It was his vision of bringing in uniform guidelines for preoperative investigation that resulted in persuading the President and Secretary of Indian Society of Anesthesiologists to formulate a core committee of 7 members for formulation of these guidelines. And I feel really privileged to be a part of this core committee team. And from the core committee, an expert committee was constituted, which involved anesthesiologists who were subject experts from various parts of the country, uniformly representing all parts of our country. And then, with the help of expert committee, the core committee prepared research questions. And for each research question, systematic literature search was done, and suitable articles were selected, which based on which systematic review was done, and wherever possible, a meta-analysis was also attempted. Now, as a distilled summary of all this process, finally, we could bring out these guidelines. So the core committee for the ISA guidelines included these 7 members on the left side of the screen, and the President and Secretary of Indian Society of Anesthesiologists, which is in the right side of the screen. Now, the expert committee specifically for preoperative investigations included 16 subject experts from various parts of India and 1 biostatistician. With the help of these experts, the core committee initially formed a preamble for preoperative investigations. The guidelines which we are presenting, they are to promote judicious ordering of investigations with focus on the perioperative management strategies. These guidelines are to aid in better patient outcomes, considering significant variation in the geographic, demographic, and socio-economic aspects in our country, and also considering keeping in mind the medico-legal aspects also. These guidelines are formulated specifically for ASA physical status 1 and 2 patients who are scheduled for elective surgical scenarios, and we did not include, or we specifically excluded specialty surgeries such as neurosurgery, cardiothoracic surgery, vascular surgery, and transplant surgery. The objective of these guidelines was to recommend minimum required routine investigations that may influence the perioperative outcome or determine the anesthetic management for these scenarios, that is minor surgery, intermediate surgery, and major surgery in patients who have ASA physical status 1 and 2 scheduled for elective surgeries. Now, to summarize this in a few sentences, what we actually wanted was to recommend minimum required routine investigations as a starting point for various types of surgeries in ASA physical status 1 and 2 patients who are scheduled for elective surgical scenarios. Now, while formulating these guidelines, we wanted them to be evidence-based, and therefore, when we say this is a minimum investigation that needs to be done, it means that it may impact the outcome or anesthetic management in some way or the other in several patients, and that's why that particular investigation would be advised. While doing this, we also had to keep in mind the medico-legal aspects also. So, in order to protect practitioners' interests also. So, considering all these things, the guidelines have been formulated. Now, overall, the attending anesthesiologist takes the full and complete responsibility for the ordering of investigations and ensuring the safety of the patient. So, what it means is, suppose somebody is in a PSC clinic and they evaluate the patient who is scheduled for a particular surgery and they order a specific set of investigations based on the guidelines. However, on the day of surgery, the attending anesthesiologist might be a different person. So that person needs to review the history and physical examination of the patient once more, and then if necessary, they need to order further investigation. So full complete responsibility rests on the anesthesiologist who is going to finally take care of the patient. Hello? ಹೇಳಿ. Okay. 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 ಮಾತಾಡ್ತೀನಿ ಅವ್ರ ಹತ್ರ ಮಾತಾಡ್ತೀನಿ. ಯಾ ಓಕೆ, ನೋ ಪ್ರಾಬ್ಲಮ್. ಸರಿ, ಓಕೆ, ಸರಿ, ರೈಟ್. Now, when we consider ASAPS and 1 and 2 population, we should understand that the guidelines should not be substituted for good clinical judgment. So, every anesthesiologist should have a detailed history and clinical evaluation of the patient and review the medications that the patient is on. And based on that, over and above these minimum recommended investigations, they should identify the areas and ask for additional investigations as necessary. Now, when patient who belongs to an ASA physical status 2 is specifically presented for surgery, when a patient has an underlying comorbidity, the decision to order investigations based on that particular comorbidity, we are leaving it to the discretion of the attending anesthesiologist. So if suppose a patient who is a hypertensive is scheduled for surgery, all we know is yes, hypertension is under control, but the patient may be on variety of medications for that, and there may be other symptoms related to hypertension, and based on these things, the attending anesthesiologist should take additional investigations as they feel necessary. Similarly, when ASF physical status 3 and above, that kind of patient is presenting for surgery, they're not suitable for elective surgery and they have severe comorbidities, and therefore they need to be sent for specialist consultation for optimization and further testing. And so we did not want to bring guidelines in that area because the specialist will decide on what set of investigations are necessary and how often they need to be repeated till the patient gets optimized and becomes suitable or fit for undergoing elective surgery. For emergency surgeries, these guidelines are not applicable because during emergency surgery, the physiological status of the patient may differ from person to person. The urgency of the nature of the surgery can be different. Somebody who has a debridement might wait for a few hours, and so we can order certain investigations and wait for them to come before proceeding with the surgery. On the other hand, somebody who has ruptured aneurysm, they might have to be taken instantly for surgery without awaiting for the investigations. So we cannot really bring in a specific set of guidelines, because if we say a particular investigations need to be done, then that investigation, if it takes time for the investigation report to come, we cannot keep waiting for the surgery. Therefore, depending on the infrastructure that is available, patient physiology, the alterations in the patient physiology, and the nature of urgency of the surgery, the attending anesthesiologist should use discretion about ordering the investigations and whether to await for the investigation report to come before proceeding with the surgery. Now, we are not concentrating on the screening test. That is not the focus of these guidelines. Say viral markers or detecting the possible underlying pathology such as diabetes or some renal impairment or something like that. That is not the focus of these guidelines. What we want through these guidelines is to specifically know if a particular investigation has to be ordered, then it should in some way be improving the patient outcome or may help in changing the anesthetic management strategy. That is the goal or objective of these guidelines. And we believe separate guidelines are necessary to address pediatric population, bariatric population, and obstetric population, as their physiology is somewhat significantly different from the patient population that we are focusing for these investigations. Now, while doing the literature search, we had specific inclusion criteria, and only those articles that met this stringent inclusion criteria were included for systematic review. And from among those articles, if they assessed only the cost analysis as the outcome, or they did not mention the ASA grading properly, or they included surgeries which we did not intend the guidelines for, those were eliminated from the systematic review. When we collected the evidence, we broadly had 10 different research questions, and a systematic review was synthesized based on the grade protocol. And in fact, for this, we took the help of Dr. Garden Guyot, who is from Canada, and he's the father of this grade protocol. So he actually helped us in proper systematic review for formulation of these guidelines. And we approached the biostatistician for possibility of meta-analysis wherever possible. So these were the such strategies that were used for evidence collection. Then the first step that we took while formulating these guidelines is to categorize the surgeries based on duration and invasiveness. Since we did not have a proper idea of these things, what we did was from those 16 subject experts that we had, we requested the experts after collecting a commonly performed surgeries. We had about 30-40 commonly performed surgeries, and we gave them to the subject experts, and anonymously they categorized these surgeries into minor, intermediate, or major based on both the duration of surgery and the invasiveness of the surgery. So once we had this data, we saw where experts were in agreement. More than 75% of the experts felt that a particular surgery comes under minor or intermediate or major category. Those surgeries we have taken as examples and presented over here. And based on this, we have categorized the literature evidence that we had into minor, intermediate, and major. And based on that, guidelines were developed. Now, to arrive at recommendations, we had a significant number of virtual meetings through the Zoom platform with experts among the core committee members ourselves and with the biostatisticians, along with 2 meetings specifically with Dr. Garden Guyot. So with all these things, finally, we formulated the draft guidelines. So when we made draft recommendations, if the level of evidence that we had was high, or one moderate level of evidence, then only more than one moderate level of evidence, then only the recommendations can be worded as recommended. And when we had a weak recommendation, we use the term suggested. And in our guidelines, since we did not have systematically done studies and the evidence was weak overall for all of them, so we have uniformly used the word suggested for all our recommendations or guidelines. And once we had these draft recommendations, though these recommendations were very clearly made based on the evidence that was available, but it is possible that we might have overlooked something and there may be a small deviation from what it should be. So in order to make sure that there is a strengthening of those recommendations based on consensus, what we did was we formulated a Delphi methodology based consensus. So through email, we gave all the systematic review on the literature evidence that we had and shared it with all the experts. And then we sent the draft recommendations to them for an anonymous Google Form survey. And each expert was to see the evidence that was collected, the systematic review, and then see the draft recommendations. And they had option of either accepting the recommendation or rejecting the recommendation or suggesting the review. If they say a review is necessary, then they need to ask what exactly they want. They can either suggest a revision or they might ask for certain clarifications. So only when the expert consensus was more than 75% in favor of either accept or reject the recommendation, suitable modification was done. And when they had asked for review, it was that research question and the recommendation was subjected for a second round of Delphi consensus, which was again anonymous. And if nothing was solved or something was pending even after the second round of Delphi consensus, it was postponed to the third round. This was an open round of meeting where all the experts participated and actively deliberated, and finally they came to a consensus about the remaining draft recommendations, and then only the recommendations were framed as final recommendations. So this improves the strength of our recommendations. So the first research question that we addressed was, in ASA physical status 1 and 2 patients scheduled to undergo elective surgery, will routine preoperative complete blood count testing change the anesthetic management or patient outcomes after surgery? Now, after the review of literature, what we found was, for intermediate and major surgery, definitely complete blood count testing is essential, as it does affect the anesthetic management plan or the patient outcomes after surgery. But the evidence was not so clear regarding the minor surgery, and therefore, based on the expert consensus and taking their inputs, final recommendation was brought, which says CBC or complete blood count should be done or is suggested to be done for patients undergoing any of the surgeries, any elective surgery. CBC is to be done. The second research question was regarding the renal function testing. Now, for renal functions, mainly we consider blood urea and serum creatinine. However, what we know very clearly is that blood urea may be altered because of alteration in the liver function also, and when the person is dehydrated, the blood urea can become abnormal, and therefore it is not a very reliable pointer to renal function testing. And when estimated GFR is considered, even that takes creatinine into account. So serum creatinine seems to be a much better predictor of renal function testing, and hence the recommendations were formulated based on the serum creatinine estimation. So recommendation 2A is, preoperative serum creatinine estimation is not suggested for patients undergoing minor surgery. So when we had evidence review, what we found was, some of the patients who underwent minor surgery, they had creatinine of 2 or 2.1 or 2.2, but they were totally asymptomatic. There was nothing suggestive of any renal pathology. So irrespective of their starting serum creatinine, the outcomes or the anesthetic management did not change at all when they were undergoing minor surgery, and hence we don't suggest use of serum creatinine as a preoperative investigation for patients scheduled for minor surgery. However, for intermediate and major surgery, we suggest serum creatinine routine evaluation prior to elective surgery. Now, regarding serum electrolytes, essentially we had literature available for sodium and potassium. So what we found was, serum sodium and potassium estimation routinely in a preoperative scenario for ASAPS 1 and 2 patients did not affect the anesthetic management or the patient outcomes, and therefore the recommendation is not suggested to do serum potassium or sodium estimation is not suggested to be routinely done preoperatively for ASAPS 1 and 2 patients undergoing any type of these elective surgical procedures. However, we need to remember that even though it is a ASAPS2 patient, if the patient is a known hypertensive and is well under control, and the patient may be on AC inhibitors or angiotensin blockers, which might affect the serum electrolytes. In such scenarios, based on the history evaluation and the medication review, the attending anesthesiologist can order for these investigations where they feel it is necessary to be done. Similarly, a patient may be ASAPS1 but is scheduled to undergo a transurethral resection of prostate. Now we know that during transurethral resection of prostate, significant irrigation fluid is used and it will be absorbed systematically to varying degrees, and that might alter the electrolyte values, and therefore in such situations serum electrolyte estimation prior to surgery is definitely necessary. So attending anesthesiologist, based on the surgery and the necessities or the comorbidities of the patient and the medications, they can have additional request for these investigations in select populations and conditions. Now, regarding the liver function testing, there were no evidence to suggest that doing routine liver function testing in patients undergoing minor and intermediate surgery is beneficial, and therefore recommendation 4A is, preoperative liver function testing is not suggested for patients undergoing minor and intermediate surgery. However, for major surgery, liver function testing routinely in the preoperative period is suggested. Now, the fifth question was to address the coagulation profile. Now, bleeding and clotting time, they have been outdated now with the advent of autoanalyzers being available in most scenarios. We are going for laboratory parameters, and hence coagulation profile, that is refers to specifically prothrombin time and activated partial thromboplastin time. So we evaluated the literature evidence for these tests, and the literature evidence has suggested that preoperative coagulation profile, that is PPINR and APTT testing, is not suggested for patients undergoing elective minor, intermediate, and major surgery in ASI physical status 1 and 2 patients. However, again, there is a rider over here. If suppose we are planning for central neuraxial blockade or regional blocks, and the patient may be on some medications which might alter the coagulation profile, or in patients who have certain history pointing towards coagulation abnormalities. In such scenarios, the attending anesthesiologist, again, based on proper clinical evaluation, history, physical evaluation, and medication review, and considering the plan of anesthetic intervention, they are free to ask for additional coagulation profile investigation. The sixth recent question was regarding blood glucose estimation. Now, see, if a patient is diabetic, it is obvious answer that yes, their preoperative blood glucose estimation has to be done. So we considered the non-diabetic patients for our purpose, research purpose. So when we say non-diabetic, who are the non-diabetic population? Patients are considered as non-diabetic if during pre-anesthetic evaluation there is no history or clinical finding or previous investigation report that is suggestive of diabetes mellitus. So we rule out the possibility of diabetes mellitus by interacting with the patient, evaluating the patient, and seeing their medications and investigations. And then we are convinced that there is nothing suggestive of diabetes. So in such patients, it is not necessary to do routine blood glucose estimation, irrespective of the type of surgery that they are undergoing. Research question 7 is regarding a 12 lead electrocardiogram testing. Now, again, if a patient has some cardiac pathology or anything that will affect the cardiovascular system, like hypertension, ischemic heart disease, or chronic COPD, or long-term diabetes, yes, ECG testing is necessary. However, in a non-cardiac status of the patient is reflected by absence of history or clinical findings or reports suggestive of cardiovascular disease. So, in these patients, routinely doing ECG for all age groups does not make sense. So when the evidence review was done, what we found was a routine ECG evaluation for minor and intermediate surgery was not really necessary. However, when we consider a larger perspective and saw the prevalence of cardiovascular diseases in our country, there are a lot of articles which have emphasized the fact that the prevalence of cardiovascular diseases and the ischemic heart disease itself is increasing in Indian population beyond the age of 45 years. So considering that and giving weightage for that, what we rephrase recommendation 7A, and that is in non-cardiac patients, preoperative 12 lead electrocardiogram testing is suggested at age 45 years and above when scheduled to undergo minor and intermediate surgery. However, if a patient is scheduled to undergo a major surgery, ECG needs to be done for all the patients, irrespective of their age. Now, the eighth research question was addressing chest X-ray testing or imaging. And the thing is, when we do chest X-rays routinely, quite a lot of patients, maybe because of the pollution or maybe because of some underlying pathology which was there long ago, like tuberculosis, which could have been there several decades ago. Some minor changes in the X-ray is prevalent in many routinely done chest X-rays. However, do they make any impact on the anesthetic management or outcome of the patients? No. If suppose you assess a patient and the patient can climb 2 to 3 flights of stairs without becoming breathless or symptomatic, then it doesn't look, X-ray testing has any meaning or any value. It cannot contribute to any additional value. And therefore, based on the evidence, recommendation 8A is that preoperative chest X-ray testing is not suggested for patients undergoing minor surgery. However, for patients undergoing intermediate and major surgery, it is suggested for patients aged 50 years and above, considering the environmental factors and the fact that the pulmonological changes keep decreasing, or functioning decreases, and some changes that we detect of over and above the age of 50 years might influence the management. So, these recommendations were mainly done not exactly based on the evidence itself, but it was considering the evidence, and also, there was actually lack of evidence, so it was based on mainly on the expert consensus. The ninth research question was related to ultrasonographic airway assessment. See, now ultrasound is becoming increasingly available as a tool for anesthesiologists, and many anesthesiologists are acquiring the necessary skills to use the ultrasound for patient evaluation, especially for point of care ultrasound. And therefore, a lot of literature is already available related to airway evaluation of ultrasound as a predictor for difficult laryngoscopy. That is, if you do ultrasound airway evaluation using ultrasound in the preoperative period, ultrasound can predict a poor view of glottis or a better view of glottis. To that extent, it seems to be useful. And we found that there were actually 22 articles focusing on this area of ultrasonography. The problem that we found was, yes, ultrasound seems to be a very useful tool for predicting a difficult laryngoscopy. However, these 22 articles differed significantly in the airway parameters they have analyzed and concluded to be useful. So, until a clear and precise information becomes available regarding maybe a combination of two or three parameters which can predict reliably the difficult laryngoscopy. Right now, the recommendation is it is not suggested for predicting difficult laryngoscopy. This, while framing this recommendation, we also considered the availability of widespread availability of ultrasound is still not there in our country, and our anesthesiologists are not uniformly skilled in its routine use for area assessment. And considering all these factors, this recommendation was formed. The last research question that we addressed, which is not there as a part of any of the other guidelines that are available across the globe, that is about validity time for previous investigations. For example, you have a person who is scheduled for a surgery, and then for some reason the surgery gets postponed, or this patient had just like that gotten some investigations done previously. Now that patient brings those investigations to us, and we are in the process of subjecting this patient for surgery today or tomorrow. Now we need to consider whether those previously done investigations can be considered, or we need to repeat these investigations based on the guidelines, or based on what we feel at that point of time. So we wanted to answer this question, and we found two suitable studies which had addressed these concerns. In fact, one study was very well conducted and had 235,000 ASA physical status 1 and 2 patients involved in that study. And based on the outcomes of these studies, we have come to conclusion and recommend that the acceptable validity time, that is the VT-TIN, for a previously performed normal complete blood count, normal renal function test, or normal liver function test, or normal coagulation profile is suggested to be 2 months, provided the clinical condition of the patient has not changed in the intervening period. Say about 6 or 7 weeks ago, somebody had gotten these tests done and they were normal, and in the intervening period of 6 7 weeks, the patient's physiological condition has not changed. Patient remains stable. In such situations, we need not have to ask for repeat investigations. We can take those values and go ahead with the necessary anesthesia plan and surgery. Similarly, the acceptable validity time for a previously performed normal 12-lead electrocardiogram and chest X-ray is suggested to be 12 months, provided the clinical condition of the patient has not changed in the intervening period. But any time in this 12-month period, if we feel the patient has deteriorated, or there is a change in the patient's status, has developed some new symptoms, or there is a change in the patient physiology, we can order for repeat investigation, definitely. So this slide summarizes all the investigation recommendations. So the pale green refers to a weak recommendation of this investigation to be done in this particular type of surgery, and pale pink or amber color refers to this particular test is not suggested for this particular surgery. Now these are the summary of guidelines, and as a part of living guidelines, we will continue to accumulate evidence as and when it comes related to the preoperative investigations. And if any time the evidence suggests that there has to be a change in the guideline, we will update the guidelines as and when necessary. So to summarize, complete blood count needs to be done for all elective surgeries in ASAPS 1 and 2 patients, irrespective of the nature of the surgery. Renal function tests need to be done as a preoperative investigations before intermediate and major surgery. Liver function tests are suggested only for major surgery. 12 lead ECG for minor and intermediate surgery for patients aged 45 years and above. Yes, it needs to be done. For major surgery, irrespective of the age of the patient, 12 lead ECG is suggested. Chest X-ray is not suggested for patients undergoing minor surgery, as it doesn't impact the outcome anyway, provided the patient is asymptomatic and physiological capacity is good. And it is suggested for patients undergoing intermediate and major surgery if their age is 50 years and above. And the validity time for lab investigations is 2 months, provided the underlying condition of the patient is stable in these 2 months. And for ECG and X-ray, it is 12 months. Thank you very much.